గుడ్ మార్నింగ్ శ్రీకాంత్. శ్రీకాంత్
గుడ్ మార్నింగ్ సార్.
గుడ్ మార్నింగ్.
ఒక చోట నుంచి ఇంకో చోటకి వెళ్ళడానికి కొంచెం కష్టపడుతుంది. సార్ స్క్రీన్ విజిబుల్ కదా సార్?
కనిపిస్తుంది. అక్యూట్ కిడ్నీ ఇంజరీ అసోసియేటెడ్ డెలీరియం.
డెలీరియం సార్, ఏం చెప్తాను చూడాలి సార్. స్లైడ్స్ మూవ్ అవుతున్నాయి కదా?
అవుతుంది.
ఓకే సార్.
Is delirium related to only AK అంతేనా?
ఏకే రిలేటెడ్ డెలీరియం మీద యాక్చువల్ గా స్టడీస్ బాగా తక్కువ ఉన్నాయి సార్, అందుకనే కొంచెం డిఫరెంట్ గా అనిపించింది టాపిక్. వీళ్ళు కూడా అంటే ఐ మీన్ లైక్ ఈ ఆర్టికల్లో కూడాను చాలా లైక్ పర్టికులర్లీ రిలేటెడ్ టు ఏకే ఇంకా ఫ్యూచర్ స్టడీస్ ఎక్కువ ఉండాలి. సో అవుట్కమ్స్ లో కూడా డెలీరియం వల్లే ఐ మీన్ లైక్ దే ఆర్ ప్రొలాంగింగ్ ద మార్బిడిటీ అండ్ ఆల్ అని ఎస్టాబ్లిష్ చేయడానికి ఇంకా ఫ్యూచర్ స్టడీస్ కావాలి. బట్ దే హ్యావ్ లైక్ కొన్ని బాగా నచ్చాయి సార్. బేసిక్ గా సెలెక్ట్ చేసుకోవడానికి రీజన్ ఏంటంటే, ఒకటి ఈ అనాలిసిస్ ఎడిషన్ ఆప్టిమైజేషన్ బాగుంది సార్. అండ్ ఆల్సో యాంటీబయాటిక్స్ అంటే కొన్ని అసలు నాకు సిన్సియర్ గా అంటే నేను బేసిక్ గా క్రిటికల్ కేర్ లో కొంచెం ఇంకా బేబీ స్టెప్స్ అండి. బట్ ఈవెన్ దాని సెఫిపైమ్ తో కొన్ని అలాగా ఆ డ్రగ్స్ మీద బాగుంది సార్ అంతను. సో అంటే ప్రాక్టికల్ పాయింట్స్ కొన్ని ఉన్నాయి అనమాట. ఏకేలో ఏ డ్రగ్స్ మనం అవాయిడ్ చేయొచ్చు అవన్నీ. అండ్ డయాలసిస్ మీద కూడా కొన్ని పాయింట్స్, అంటే ఎక్స్టెన్సివ్ గా డెప్త్ లో వెళ్ళదు కానీ బట్ దేర్ ఆర్ సమ్ ప్రాక్టికల్ పాయింట్స్ రిలేటెడ్ టు ఏకేఎస్.
ఓకే.
సో డెలీరియం అసెస్మెంట్, క్యామ్ఐసియూ స్కోరింగ్, ర్యాస్ స్కోర్ విన్నాను కానీ క్యామ్ఐసియూ అది బాగుంది సార్. కొన్ని అలా చూసాను.
గుంటూరు వెళ్తున్నావా?
తప్పదు కదా సార్, ఫ్యాకల్టీ.
ఎప్పుడు?
నాది సండే మార్నింగ్ సార్, 10:20కి టాక్ సార్, హాల్ బిలో. అక్యూట్ పెయిన్ లో సార్, ఫార్మకోథెరపీ ఆఫ్ అక్యూట్ పెయిన్, వాట్స్ న్యూ. మార్నింగ్ 10:20కి. ఫ్రైడే నైట్ బయలుదేరి వెళ్తున్నాను సార్. సాటర్డే మధ్యాహ్నం మా కొలీగ్ ఇంకా సాయిబాబా అని నాతో పాటు ఎండి బ్యాచ్మేట్, తను ఫస్ట్ టైం చెప్తున్నాడు. నాది 3rd టైం సార్ కన్సిక్యూటివ్ గా. ముందు 2 సార్లు ఆన్లైన్ లోనే అయిపోయింది, ఈసారి రంగస్థల ప్రదర్శన. అదే సో ఫస్ట్ టైం 20లో సర్వైకల్ ఎపిడ్యూరల్ చెప్పాను క్రానిక్ పెయిన్ లోనే. 21లో మల్టీమోడల్ ఎనాలజీస్. ఈ ఇయర్ లాస్ట్ ఇయర్ అక్యూట్ పెయిన్ సార్. ఫార్మకోథెరపీ వాట్స్ న్యూ అని కొంచెం మిక్స్ అండ్ మ్యాచ్ లో.
విష్ణు మహేష్ దీనికి కూడా సైంటిఫిక్
సరే సార్, వరుసగా 7th టైం అంట ఆయన. స్టేట్ అకాడమిక్ కమిటీ చైర్మన్ కింద. మీరు వస్తున్నారు సార్?
నాది ఈ రోజు నైట్ బయలుదేరుతున్నాం, రేపు వర్క్ షాప్, వెంటిలేటర్ వర్క్ షాప్ మాది.
మీరు వెంటిలేటర్ వర్క్ షాప్ కదా సార్? మా దాంట్లో అదే కేజీహెచ్ అసిస్టెంట్ ఒక అబ్బాయి వెంకటకృష్ణ అని ఏఎఫ్ఎంసీలో చేసి వచ్చారు. తను మా దగ్గర నైట్ డ్యూటీలు చేస్తాడు. తను రీజనల్ అనస్థీషియా దాంట్లో ఫ్యాకల్టీ కింద ఉన్నాడు. యాంకిల్ బ్లాక్స్, నీడ్లింగ్ అండ్ యాంకిల్ బ్లాక్ తనకి ఇచ్చారన్నమాట ఆర్ఏలో. అదే వెంటనే రేపు ఇంకా అందరూ స్టార్ట్ అయిపోతారు కదా ఇవాళ నైట్ కి. రేపు అని ఇంకా రేపు ఫ్రైడే క్లాస్ కేర్ది నవీన్ చెప్తా అన్నాడు. అది నెక్స్ట్ వీక్ మార్చ్. ఎవరు ఉండరు కదా సార్ ఇంకా, అది నెక్స్ట్ వీక్ మార్చ్. అనురాధ మేడం గుడ్ మార్నింగ్.
గుడ్ మార్నింగ్.
నిన్న నవీన్ ఫోన్ చేశాడు మేడం. నవీన్ ఫోన్ చేస్తే ఇంకా అదే చెప్పాను, స్టేట్ కాన్ఫరెన్స్ స్టార్ట్ అయిపోతుంది కదా, నెక్స్ట్ వీక్ పెట్టుకుందాం అని చెప్తాను.
అలాగే.
ఓకే.
గుడ్ మార్నింగ్ సార్, డేవిడ్ సార్.
గుడ్ మార్నింగ్ అనురాధ. ఏది మన వాళ్ళు ఇంక రాలేదు, నిద్ర లేవలేదా? Shall we start, Srikanth? It is
Yes, sir.
6, so slowly they will join.
Okay, sir. Okay, sir.
Okay, good morning all. Today, Dr. Srikanth is a consultant in anesthesia and critical care. He's going to talk on acute kidney injury associated delirium and what is the mechanism and pathophysiology. It's a new topic, a very interesting topic. I request Dr. Srikanth to start the presentation.
Thank you, sir. So good morning, everyone. So first of all, even though practicing since 10 years in anesthesia, this is actually a relatively new topic to me. I mean, like we all know the AK is very common in our ICU patients, and delirium is also pretty much common. We'll see in renal failure, hepatic failure, and also directly cerebral related. And also we see a particular condition where after a few days of ICU stay, they get ICU psychosis and so. But what made me like choose this topic is this. Actually, there are very few studies even today to establish exactly the prognostication of long-term outcome and all of delirium specifically associated with kidney injury, and it's that point itself is mentioned many times in the article. But even then, so the clinical and pathophysiological mechanisms, and also there are some beautiful points regarding the drugs and certain antibiotics and analgesic sedation optimization and the future treatment modalities. All these took some interest for me to present this topic. So we'll go into the details of this one. So coming to background in epidemiology, AK is estimated to affect more than 10 million people worldwide annually. This confers to a 1.7 to 6.9 fold increased risk of hospital mortality. Over half of critically ill patients develop AK within 48 hours of admission into ICU. So coming to AK delirium, sorry, AK-induced delirium presents as an acute or fluctuating impairment in attention, executive function, or short-term memory. So it's strongly associated with increased mortality, prolonged hospitalization, and need for intensive medical interventions. Persistent cognitive decline is a feared long-term sequelae where there is a very good study called Brain ICU study conducted, where they found that around 20% of these patients who developed delirium, they went into a long-term persistent cognitive decline, which is almost similar to Alzheimer's disease. So coming to the few definitions, AK is defined as an absolute increase of serum creatinine of more than or equal to 0.3 or relatively more than 1.5 times the baseline. According to this, many studies have quoted this guidelines of KDIGO, when kidney disease improving global outcome, where the stages and accordingly the prognostication. Stage 1, its creatinine is 1.5 to 1.9 or increase of more than 0.3 milligram per deciliter of absolute value. Stage 2 is 2 to 2.9 times the baseline, and stage 3 is more than 3 times the baseline. So coming to the assessment of delirium, this RAS score, where 0 is the normal, alert and calm person, and the positive side, it is hyperactive delirium, and the negative side is hypoactive delirium, which is actually less diagnosed and even less treated. So we are not going into very much details of all those. You can just have a casual look over there. And if the RAS score is more than 2 in hyperactive delirium, we will proceed to another assessment called CAM-ICU assessment. And if it is less than 2 in hypoactive delirium, we will again reassess and take measures to decrease the delirium. So hyperactive is defined as RAS score more than or equal to 1 and no 0 less or less than 0 in the follow-up scores. Hypoactive was defined as RAS score less than 0, whereas mixed delirium was defined as a variable positive and negative RAS scores. It's like the patient will be alternating. Sometimes you'll be having hyperactive delirium and sometimes you will be having hypoactive delirium. So this is the CAM-ICU, like confusion assessment method for the ICU. So Most of you may be knowing this, but this is new for me actually. So we'll see initially acute change or fluctuating course of mental status. Is there an acute change from mental status baseline? I mean, like when he was admitted or and then we have to assess, has the patient mental status fluctuated during the past 24 hours? So if the answer is no to both of these, then there is no delirium. We can certify as no delirium or CAM-ICU negative delirium. And then if the answer is yes, then inattention. You have to see for the attention deficit. So this is a method, squeeze my hand when I say the letter A. We will give a sequence of letters. Whenever the letter A comes, they have to squeeze the hand. Errors means no squeeze with A or squeeze on any other letter other than A. If unable to complete letters, we can try with pictures. So if there are 0 to 2 errors, it is called CAM-ICU negative delirium. And if it is more than 2 errors, we will assess for the level of consciousness, which again moves to RAS scoring. So if the RAS is 0, then we will assess about thinking. So disorganized thinking, like will a stone float on water, are there fish in sea? So see, these are basically designed in the Western world, and we can actually make some changes. We have to primarily assess the recent change in sensorium, and then we have to assess for attention and level of consciousness and thinking. So these things are primarily assessed in this CAM-ICU flowchart. So this is the brain ICU study, which was published in New England Journal of Medicine, NEJM, stopping. So if you see the conclusion, patients in medical and surgical ICUs are at high risk for long-term cognitive impairment. A longer duration of delirium in hospital was associated with worse global cognition and executive function scores at 3 months and 12 months post-ICU. So there is a very high chance of long-term cognitive decline, at least in 20% of patients according to this study. So these are the few studies, clinical studies investigating the association between Aka and delirium, where the higher grades of Aka or KIDCO stage 3 was associated with more incidence of hyperactive delirium. Also, the absolute serum creatinine level also plays a major role. So, sorry, coming to the pathophysiology of Aka-induced delirium. So we all know a broad idea of delirium will be obviously caused by the neurotoxic effects of either the toxins which are accumulated due to renal failure or the impaired drug clearance. The first 2 points are very clear. The direct neurotoxic effects of Aka from endogenous toxin accumulation and from drug accumulation. And the third one is Aka-associated systemic and brain inflammation. All these toxins will obviously cause the inflammation, will trigger the inflammation cascade. And then Aka-associated fluid overload and hormonal and neurotransmitter effects of Aka. So coming to some, the first thing, the toxins, even though urea is generally graded as a standard, but there are these compounds are the one which are the main culprit according to various studies. So these are called uremic guanidine compounds, which include creatinine, guanidine, and guanidinosuccinic acid and methyl guanidine. Among these, they state that the guanidinosuccinic acid is more associated with the incidence of delirium in AKA patients. So how these toxins actually act? These act through inhibition of GABA receptors and activation of Nmda receptors. These two are the main pathways through which they exhibit the effects. So the inhibition of GABA receptors and activation of Nmda will cause neuronal hyperexcitability, abnormal epileptiform activity, and hippocampal injury. So coming to the neurotoxic effects from the drug accumulation. So these are very like the common drugs we use, benzodiazepines, which is having elimination through kidney. Midazolam is having elimination through kidney. We will talk about this in more detail when we come to treatment part or optimization part of delirium. So here I want to mention about this particularly cefepime, which is fourth-generation cephalosporin we commonly used to use in ICU. So cefepime induced neurotoxicity is relatively commonly implicated in the precipitation of delirium, according to many studies, and they have observed almost 15% of patients who are treated with cefepime. This drug is bound to cause delirium, acute delirium. And also, given that cefepime is renally cleared, so in case of AKA, it is better to optimize the dosage of cefepime, or if possible, completely, totally avoid giving cefepime and look for alternatives. So this drug is known to cause non-convulsive status epilepticus in AKA patients. And we'll go in more detail about opioids later in the drug, and also meperidine. Its metabolite normeperidine is a common culprit in causing of AK-induced delirium. So coming to AK-induced systemic and brain inflammation. So AK promotes upregulation of systemic inflammatory process that contributes to endothelial injury, leukocyte infiltration, release of cytokines and inflammatory mediators, and induction of apoptosis. So this in a nutshell is the various mechanisms through which AK causes the delirium. So the impaired clearance of toxins and drugs, including sedatives we talked about, and we are going to talk in the further slides. We all know AK is bound to cause electrolyte abnormalities, which in cause hyponatremia. All these are known culprits in causing delirium, and also the seizure activity. Hyponatremia is bound to cause seizures, and increased vascular permeability, which will cause disruption of blood-brain barrier and which will lead to cerebral edema. Also, the fluid accumulation due to AKA, which can lead to cerebral edema. And coming to the monoamine metabolism, depressed central dopamine turnover is also one of the pathway to causing AK-induced delirium. And inflammation will cause upregulation of toll-like receptor 4 in hippocampus and striatum. These are the brain areas which are affected most in acute kidney injury. Increased KC, GCSF, and MCP1, all these proteins in cerebral cortex and hippocampus, and increased glial fibrillatory acidic protein expression in the astrocytes in cerebral cortex and corpus callosum, and increased pycnotic neuronal cells and microglial cells in hippocampus. These are the brain changes that occur due to AKI, which will lead to the delirium. So this is what happens from periphery to the CNS, how they cross the cytokine release and AK-induced systemic inflammation. They will cause the blood-brain barrier disruption and enter of the inflammatory mediators into the brain. So astrocytes and microglial activation is the major change that is going to happen in brain, and is documented by microgliosis in various brain tissues in autopsies and all in cases of AK-induced delirium. And neuronal dysfunction and injury, all this will cause hippocampal injury, neuronal dysfunction and injury, which will lead to delirium. So the main changes to talk about the blood-brain barrier disruption, altered expression of tight junctional proteins, increased brain vascularity, microvascular protein leakage, and alteration of aquaporins, which will lead to accelerated brain damage. So the infiltration, through these infiltration of metabolites and toxins into the brain happens, brain injury and cerebral edema occurs. So the clinical evidence of blood-brain barrier disruption serving as a pathophysiological role in delirium is provided in one study that showed the elevation of serum levels of S100 beta, which is a marker of blood-brain barrier damage in elderly patients with delirium. So this is the evidence that shows the disruption of blood-brain barrier plays a major pathophysiological role in AK-induced delirium, the elevation of this particular marker. So coming to fluid overload, again, there are very limited documentation studies or major RCTs suggesting the fluid overload as a direct cause of acute delirium, but it is thought to increase the capillary transmural hydrostatic pressure, resulting in fluid leak into brain interstitial tissue, causing cerebral edema. And Gwen et al. Hypothesized that the mechanism behind is again the vasogenic edema due to blood-brain barrier leakage, as evidenced by increased serum S100 beta. So coming to the hormonal and neurotransmitter effects, this Adachi et al. Study changes in monoamine metabolism and motor activity in AK rats found in overall decrease in dopamine turnover in the striatum, mesencephalon, and hypothalamus of AK rats. So this results in impaired spontaneous motor activity, memory, learning, anxiety, and cause anxiety and depression. So another changes in the coming to neurotransmitter and hormonal changes is increased calcium content. They have studied in canines, just like where they concluded that there is increase in calcium contents in gray and white matter, which are actually markedly increased 3 days after the onset of AKA, with modest increments of magnesium and delirium relevant regions of the brain. So coming to the important part and potential therapeutic treatments of AK-induced delirium. So one is the first renal replacement therapy and analgesic sedation optimization and potential emerging therapies. We'll be talking more in detail about renal replacement therapy and analgesic sedation optimization. So coming to renal replacement therapy, it obviously diminishes the effects of AK on the brain by clearing the neurotoxic sedatives, antibiotics, and the metabolites. So hemodialysis or peritoneal dialysis will obviously decrease toxins accumulated, and in severe acute kidney injury, it is whether due to, for delirium or not, the renal replacement therapy becomes standard line of treatment. So, but again, this pitfall, like, is this early onset of RRT? This will definitely shorten the length of stay, but it is unclear if improved delirium is the cause for this effect. So, though renal replacement therapy will decrease the length of stay and also decrease the metabolites and all in the blood, but there are still large need for larger studies to prove that the delirium factor is the one driving this effect. So ultrafiltration may be an intuitive approach addressing the AK-induced delirium due to fluid overload. But again, in other cases where their fluid overload is not there, they say ultrafiltration will actually lead to increase of delirium component. So risk of incident dementia is lower in patients on peritoneal dialysis compared to hemodialysis. So the cognitive impairment rates for patients undergoing hemodialysis are 1.5 to 2 times higher than those undergoing peritoneal dialysis. Only when we are talking about delirium, they say peritoneal dialysis offers more advantages compared to hemodialysis. So this was suggested actually to be attributable to a reduction in the hemodynamic stability, which we all know during the hemodialysis, and rapid changes in cerebral blood flow, typically seen with patients undergoing hemodialysis. So coming to analgesic sedation optimization. So when choosing sedatives, careful consideration of the respective metabolism and clearance pathways is warranted in the setting of AK. So coming to the drug used for sedation or the seizure control, midazolam versus lorazepam. So when it comes to midazolam, the metabolite of midazolam, alpha hydroxymidazolam, is highly toxic when compared to in relation to delirium. But again, the lorazepam metabolite, lorazepam glucuronate, is an inactive metabolite, and it does not, and it's relatively safe when compared to midazolam for AK-induced delirium. But again, the lock is the solvent used in lorazepam will cause propylene glycol toxicity, they say. But there are many large RCTs conducted where they say that even around 19% of the medical ICU patients treated with high-dose lorazepam infusions have developed a propylene glycol toxicity, but they had not observed any significant clinical deterioration. So, keeping in mind all these, they say lorazepam is relatively safer drug compared to midazolam in AK-induced delirium or in AKA cases. So, again, opioids with renal clearance, tramadol, morphine, codeine, and meperidine have to be carefully given or better avoided in case of acute kidney injury. And coming to morphine 6-gluconate, this particularly when among these 4 drugs, morphine is given more importance because they have observed that even after getting treated and getting dialyzed also to remove the metabolites and all, this morphine 6-glucuronate causes a long-standing damage to the brain and resulted in persistent cognitive decline. The highest risk of delirium is with meperidine and tramadol among the other opioids, likely due to high anticholinergic properties of the opioids and their metabolites. So, acetylcholine in the brain is actually associated with learning and memory mainly. So, due to the anticholinergic properties, these two drugs are bound to cause delirium, and especially meperidine, metabolite normeperidine is main culprit in AK-induced delirium. So in contrast, fentanyl is extensively metabolized via cytochrome P3A4 into norfentanyl, which is an inactive metabolite and is the preferred opioid in the AKA settings. Methadone is also ultimately metabolized into pyridine, which can be eliminated through feces, and so it is also relatively safe, but due to availability and safety profile, fentanyl is the preferred opioid in the AKA settings. Neuropathic agents such as tricyclic antidepressants are also known contributors to delirium, perhaps mediated by their anticholinergic effects. So coming to dexmedetomidine, dexmedetomidine is devoid of both anticholinergic properties and GABAergic properties. And also dexmedetomidine, in spite of all this, even if we keep aside this properties, anticholinergic and GABAergic, which will cause delirium, it will provide a more natural sleep-like sedation pattern, which may reduce the risk of developing delirium. So also it has hepatic clearance and potential renoprotective effects via stabilization of sympathetic system and anti-inflammatory toll-like receptor 4 mediated effects. So this drug will actually decrease the inflammatory toll-like receptor 4 mediated effects, which we have seen in that image, which contributes to the delirium. So therefore, in the setting of AK, it seems reasonable to use dexmedetomidine or other types of sedatives. Coming to the potential emerging therapies and future investigations, immunomodulating therapies are being largely studied, and we will see a lot of new drugs which may decrease the AK-induced delirium. And even though there are many inflammatory mediators like TNF-alpha, IL-1, IL-alpha, IL-6, but IL-6 is the most commonly studied inflammatory mediator, and also it is said to be the most common inflammatory mediator that is a causative factor for AK-induced delirium. So systemic IL-6 inhibition is the one aspect which is studied widely, used for the treatment, and also use of Nmda receptor antagonists, because as we have seen in the earlier slide, inhibition of GABAergic receptors and activation of Nmda receptors are the main culprits in causing of the inflammatory cascade and also result in delirium and brain changes. So use of Nmda receptor antagonist, we know the ketamine is being studied for its use as a delirium stopping agent or preventing agent. So this is the summary of evidence-based therapies and also emerging therapies. As you can see, there are very good studies and very recent ones on dexmedetomidine. In 2018, there is the incidence of delirium was significantly lower in dexmedetomidine group compared to placebo and also standard sedatives and opioids. So they recommend preferential use of dexmedetomidine for sedation, which also can be potentially renally protective. And also they have studied risk with different opioids in another study in 2017. So they have observed significant risk with use of meperidine compared to other opioids, and decreased with risk with hydromorphone and fentanyl. So they have recommended preferential use of fentanyl compared to other opioids. And these are there are other studies like with lorazepam and compared to diazepam and clonazepam. So these are all we discussed in the slides. And emerging therapy, like we have use of anti-IL-6 to reverse delirium-like phenotypes and mice model. This was a very recent study published in 2021. So these are still going on and needed approval to come into commercial usage and all. So this is all I could find about this topic, and found it very interesting because delirium we see commonly as a mixed package, but specifically related to AK and what we can do with the drugs and some treatment as to how to assess delirium are the things I found interesting in this particular topic. And so the pathogenesis, to conclude, the pathogenesis of AK-induced delirium is multifactorial and includes both inflammatory and non-inflammatory mediated causes. Current evidence suggests that when possible, gradual normalization of kidney function may ameliorate delirium. However, optimization of other clinical contributors such as deliriogenic drugs, including analgesic sedation and antibiotics, provides additional opportunities to mitigate delirium. Future investigations are needed to understand the role of systemic immunomodulations to emulate AK-associated delirium. Thank you so much.
Thank you, Srikanth.
Thank you, sir.
Simply and well explained about the pathophysiology of delirium, particularly in AKI. We don't usually routinely we start routine drugs like fentanyl midazolam combination and cefepime, particularly in patients of CBA and other meningitis, suspected meningitis, old people admitted with some sort of delirium, thinking that he might be having some meningitis, will start the cefepime high dose. So we came to know that what are the specific drugs to be monitored and okay, how to stop in case of in this condition. Thank you very much for enlightening on that. I request the audience to respond.
What are the important drugs, Srikanth? కొంచెం నేను మిస్ అయ్యాను, లేట్ జాయిన్ అయ్యాను. అది పీపీటీ పంపిస్తావా?
పీపీటీ పంపిస్తాను సార్, ఆర్టికల్ కూడా పంపిస్తాను సార్. బట్ ఐ మీన్ లైక్ ద మెయిన్ థింగ్ సార్, వన్ cefepime సార్ ఇన్ యాంటీబయోటిక్స్. So cefepime, they're bound to cause almost like in around 15% of patients treated with cefepime, they develop AK-induced delirium due to cefipimes, as a direct contributor. So the main related to brain they found is the cefepime causes non-convulsive status epilepticus. So they say to decrease the doses, or if better, we avoid the drug in AK patients. And then compared to midazolam, lorazepam, they say more safe. Lorazepam is the preferred drug. In opioids, fentanyl is the preferred drug. Morphine has got like prolonged actions, and due to this metabolite, morphine 6-propionate, even after dialyzing and even after treatment, it is prone to cause long-term cognitive decline in AK patients. And meperidine is another major significant factor which is contributing to AK-induced delirium. So they have given fentanyl as the preferred opioid. Methadone also can be used because it is eliminated in feces, and also the metabolite pyrroline is relatively safe drug. But due to availability and also safety profile, fentanyl is the preferred opioid. Dexmedetomidine, they say, is the wonder drugs for this particular thing because of the no GABAergic or no anticholinergic properties, and also the natural form of sleep it induces compared to other opioids. Due to that factor also, the delirium incidence is low in dexmedetomidine groups. And this future, they're seeing the role of ketamine as an Nmda receptor antagonist in the treatment of AK-induced delirium, and also IL-6 inhibition, systemic IL-6 inhibition.
AK-induced delirium, huh?
AK-induced delirium, sir.
No, just because I happened to be here, I requested my colleague Dr. Ramanayadu to join here, so he's also in the group. So if anything to contribute, Ramanayadu, ఇంకేదైనా extra add points ఉంటే చెప్పు. Hello. రామనాయుడు ఉన్నాడు కదా
సార్? నేను ఒకసారి 2 points మాట్లాడచ్చు.
చెప్పు
సార్. నేను సురేంద్ర సార్. I'm Dr. Surendra. I think I know Dr. Srikanth sir also and David sir also, sir. I newly joined in Mohan Maharashtra team, sir, in medical. Actually, sir, I listened in the last 10 minutes, but well explained, sir. Definitely, there is a very big no for midazolam in the ICU. It has only very minimal role in the only status epileptic infusion, and any acute seizure, only lorazepam used. Definitely, dexmedetomidine is the best option. I use a lot in dexmedetomidine, and I believe in dexmedetomidine. And very well mentioned, cefepime is the main culprit that causes seizures and delirium. And meropenem and imipenem, these are also some drugs that are epileptogenic. If patient is becoming delirium, what I seen case reports, I had here around 10 cases that are getting NCSs and meropenem and imipenem also, sir. So we should not neglect and carbapenem, and definitely cefepime is the main major culprit, sir. Next, sir, definitely. And I think what my mind always opioids to be decreased in the after 3 to 4 days, and we should go more with the dexmedetomidine, and we should go with the ketamine and opioid sparing because of opioid side effects. If everyone agrees, we will definitely. I am planning for a small study of opioid decreasing and dexmedetomidine more prone studies. And there is a concept of dexmedetomidine tachyphylaxis, but what I read so much literature, dexmedetomidine in low doses can be safely given up to 28 days in the ICU without any side effects. I used dexmedetomidine as a sole agent in the COVID patients for so many days. I think I have never seen any complication, but only small side effects will be bradycardia. That should be monitored closely. We should explain to the sister. Next are
Satish,
definitely AK in delirium. There could be two things. One is uremia might be the causing the thing, and there is a acute inflammatory rise of markers that is also causing the delirium. Right at this point of time, I am not much read about the olanzapine and quetiapine about it at this time. Definitely that works in the chronic states. Definitely, Dexmed definitely works in the acute stage. What I feel, sir. Thank you, sir.
thank you, Surendra.
Satish
ఏంటి సార్
సతీష్ చేయొద్దు.
అదే అందుకన్నా సతీష్.
Sir, Srikanth, nice presentation. First thing is 2-3 important issues. I just want to clarification. One thing is the topic is AK induced delirium. Is it so? One thing.
Yes, sir.
So AK, is there any direct connectivity to cause the delirium?
Direct connectivity, I mean, like,
The AK
they
causes
say about
uremia.
this drug accumulation and toxin accumulation. These are
That's
the
what.
mechanisms. Even they say in the article many times that still more large RCTs are required, and also the previous studies which have been conducted didn't see delirium as a direct factor to AKS. So even they say there are further studies needed to establish the direct causal relation. But in AK patients, delirium can be caused through these mechanisms and the changes in drugs they mentioned in this.
Yeah. One thing is that either it is drug overdose, say relatively, because it is not being excreted, drug accumulation is there, that might cause something in the brain. Second thing is some electrical disturbances are happening. That is one thing. Second thing is, third thing is there is a like osmolarity differences might happen from the brain and might cause some delirium. Over the previous discussions with the, I don't know, the new doctor, someone has explained that cefepime, everything is attributable to seizures related issue. Nothing is directly related to delirium, what we discussed here. One thing is, yes, many drugs causes seizures in the acute kidney injury with a background of intensive care setup. Like all carbapenems will have a either plus or minus, +2, -2, all these things, except some newer drugs, all the carbapenems will have a potential to develop a seizure. Cefepime develops a non-convulsive status, as you said, I agree with that. But it is never directly related to delirium. Okay, second thing. So few other things like sedatives. So we are coming from the era of diazepam to recently, the last 20 years, there's so much of sedatives in the ICU have come into the limelight. So did we experience anything wrong with the midazolam? As the seniors, Mohan Maharaj sir, Srinivas sir, all these people who started using initially diazepam, then shifted out to midazolam, now maybe shifting over to dexmedetomidine. Out of their experience and the evidence base, Does diazepam is a so nonsense drug? Midazolam?
Sir, good morning, sir.
Yes.
So basically, we stopped using since almost around 2008 or so, 7, midazolam as a combination with the fentanyl in ICU, sir.
Yes, sir.
Because
Reason, sir. Reason?
since long time, what happens, sir? This midazolam, when see the AKI issues and these electrolyte balances, imbalances, very common in ICU, specifically the AKI. You see almost 60 to 70% of the patients in the ICU will have a AKI, medical ICU patient.
Sir.
So, doesn't mean that dialysis, but AKI. So, when this accumulates, this midazolam, when it accumulates, it forms a oxymidazolam or metabolite, sir, which is active for almost 36 to 72 hours.
Okay.
So sometimes what happens when our patients, there is a AKI and we want to wake the patient up. So prolonged sedation and imaging, this is more happens with this. And coming up to fentanyl is little higher dose. It is a sedative and a good analgesic also. So we usually give around 50 to 75 mics of fentanyl per hour. These patients do better. So, but again, when we want to make the patient wake up, so we add either we stop fentanyl and put on a Dexam or a propofol infusion for an easy wake up. But
Yes, sir.
midazolam we are not using, sir. At the same time, lorazepam, as he has mentioned, lorazepam has a longer duration of action, and that is again a concern. We use only in the patients who is having, if requires lorazepam in a liver disease patient. So
Sir.
other than that, we don't use it.
Yes, sir.
That's all. Thank you.
Yes. Sir.
And I explained that fentanyl is converted by cytokine P. What is that? 450 to norfentanyl, and which is completely metabolized by the liver. Whereas midazolam is metabolized completely metabolized by the kidney, and as Srinivas said, that metabolite accumulates in the blood for a prolonged time, more than 36 hours. So accumulation of this drug with in condition of AKI causing more and more incidents of delirium when compared to dexmedetomidine and lorazepam also. Lorazepam is better than the midazolam in case of AKI.
Okay.
So Satish, sir, actually, nice question, sir. Actually, sir, in actually article much man, sir. Actually, mechanism definitely the PKPD, the molecules, wala issues, sir. The basic delirium అని వాళ్ళు యాక్చువల్లీ ఒక ఆర్టికల్ ఇచ్చారు సార్, నేను చదివాను కానీ మర్చిపోయాను, చాలా రోజులు ఏం చదివి అప్పటి నుండి అంటే దాని మీద అంత కాన్సన్ట్రేషన్ తగ్గిపోయింది. బట్ ఆ మిడజోలంకి అయితే అందరూ నో చెప్పారు, సో దాని మీద అంత ఫోకస్ పెట్టడం మర్చిపోయాను సార్. ఓన్లీ ఫెంటనిల్ వాడతాం, లేదంటే డెక్స్మెట్ వాడతాం, లేదంటే ప్రొపఫాల్ అయితే ఎక్యూట్ సెట్టింగ్ ఫర్ 24 hours, నేను డెక్స్మెట్ పెడతాం. యాక్చువల్లీ నేను అంత ఏంటంటే సార్, కొత్తగా అంటే నేను ఈ మధ్యన ఒక 2-3 ఆర్టికల్స్ చూసినప్పుడు సార్, 3rd, 4th డే నుండి ఓపియాయిడ్స్ ఆపేసి కెటమిన్ లో డోస్ లో పెట్టమని చెప్పి అందరూ అడుగుతున్నారు సార్. దానివల్ల ఏంటంటే ఓపియాయిడ్ స్పేరింగ్ ఇద్దామని, టు డిక్రీజ్ ద ఓపియాయిడ్ సైడ్ ఎఫెక్ట్స్ అని. ఓపియాయిడ్ జిఐ కానీ ఈవెన్ హై డోస్ ఆఫ్ ఓపియాయిడ్స్ బ్రెయిన్ లో కానీ దే డోంట్ నో వాట్ ద లాంగ్ సైడ్ ఎఫెక్ట్స్. దాని మీద ఇంకా పెద్ద ఆర్సిటీ రాలేదు సార్ అని చెప్పి నేను చదివాను సార్ బేసిక్. సో నేను అలా చెప్తాను సార్, ఏకే ఇట్ సెల్ఫ్ ఈస్ అ డెలిరోజెనిక్ సార్. డెఫినెట్లీ వాట్ ఈస్ అట్ 100% ఇంక్రీజ్ ద ఇన్ఫ్లమేటరీ మార్కర్స్ అండ్ ఇంక్రీజ్ ద urea level, increase the osmolality. Definitely that is one of the main cause of delirium.
Ketamine ఎంత ఇస్తారండి డోసు?
సార్ కెటమిన్ సార్ యాక్చువల్లీ కెటమిన్ సార్ ఫస్ట్ వాళ్ళ ఆ డోస్ సార్ 0.1 mg per kg, అంటే మనం 20 mg per hour సార్ ఇన్ఫ్యూషన్ ఇస్తాం సార్. 20 mg to 30 mg ఇచ్చేవాళ్ళం సార్ మేము.
Because ultimately, once we start using any drug more, then we will understand more about the drug and their side effects. Because we use ketamine only in anesthesia, and in ICU we use only for a status purposes. Other than that, as a analgesic, I have not used analgesic and sedation. It is a ketamine in ICU. But I don't know if we get a robust evidence, then we can start using it. But it's very difficult, not so easy.
సార్ ఇప్పుడైతే దాని మీద నేను యాక్చువల్లీ 2-3 ఆర్టికల్స్ వచ్చేసారు. వాళ్ళకి గైడ్ లైన్స్ లో చదివాను సార్. మన సెడేషన్ అనాలిసిస్ గైడ్ లైన్స్ అని రిలీజ్ చేశారు కదా సార్, దాంట్లో చదివాను సార్. వాళ్ళు కెటమిన్ వాడచ్చు అని ఇచ్చారు. బేసిక్ గా
విటమిన్ వాడచ్చు అని కాదు, విటమిన్ వాడచ్చు. There is no contraindication in using ketamine.
Sir.
You have so many safe drugs, but why you want to use ketamine in place of fentanyl గానీ, dexmedetomidine గానీ, ఇవన్నీ ఉన్నాయి కదా, ప్రొపఫాల్ ఉన్నాయి. ఇవన్నీ ఉండగానే మనం ketamine ఎందుకు వాడాలి?
సార్ నేనైతే సార్ 7 days తర్వాత ఒక పేషెంట్ కి కాన్స్టిపేషన్, బౌల్ డిస్ఫంక్షన్, స్టూల్ పాస్, అబ్డామినల్ డిస్టెన్స్ వచ్చినప్పుడు వాడాను సార్.
డాక్టర్ గారు అవన్నీ అందరికీ తెలుసు. You project an evidence. What is the evidence based on this in the next class? So ఎప్పుడో ఒకసారి you project the
articles in the group.
Okay sir, ఒకసారి పంపిస్తాను సార్.
They will read and understand.
Head to head comparison. We need to have a head to head comparison. Okay?
Sir. Sure sir.
Because usually the experience will be counted only very huge experience unti baga cheste ganke experience. Otherwise we all follow a evidence based medicine.
అవును సార్, షూర్ సార్. నేను మామూలుగా చెప్పాను సార్. యాక్చువల్లీ నాకు కెటమిన్ గురించి సార్ చెప్తా ఉంటే అవును సార్ కెటమిన్ కూడా యాక్చువల్లీ నేనైతే కొన్ని కేసులో వాడాను సార్. అంతే సార్. బేసిక్ గా నేను
maybe they are trying, but we send the articles, we see the safety profile and use that.
Yes sir.
Yeah, and this
David,
asked what
David
sir
అయిపోయిందా? ఒక నిమిషం మాట్లాడొచ్చా?
Yeah.
See, when I was training in PG Rhyme, and our drugs were compose, and compose is only medicine what we used to use. So compose and ఏంటి David?
Diazepam.
So diazepam is the only medicine what we used to use. Then later on midazolam has entered. When the midazolam entered to the market, that time we have already just bombarding till the time the advantage of diazepam is so great for every person, seizure, anything, we used to give only diazepam. Later on when midazolam entered to the market, everybody bounced onto the midazolam saying that diazepam having that complication, this complication, like there are 10 to 15 complications of diazepam came out. Then the same way when the fentanyl came, again it was boom like anything. So it is a strategy how it comes for any drug. And particularly if you see one sentence in anesthesia, whichever drug you are comfortable with, they will tell. Because nowadays nobody knows what is diazepam, nobody used it, so they don't know about the drug. Like that, the new doctors who are entering into that now, they will not be knowing about midazolam for some time. They'll be knowing about only these drugs like dexmedetomidine or so. Like that it happens. So it takes, as you said rightly, as Jekina told, as Satish told, we need to have a head-to-head comparison of studies. Then we can say that, okay, this is what as per this, because like ArtsNet, anything, we need to have a proper evidence, because as you said rightly, it's my experience doesn't count anything, as you said, but at the same time, we should have a head-to-head trial, which will prove in the papers, that will give us the correct thing, because we keep changing, it keep changing, we should change. As per the new evidence, we should change ourselves. That's what I think. Thank you.
Sir, in case of burns, the plastic surgeons all they are using a combination of cocktail like midazolam, tramadol, and ketamine combination. Midazolam 10 milligrams, tramadol is around 100 milligrams, and the ketamine is again 100 milligrams. So they mixed with saline and give around 3 to 5 ml, depends on the weight, body weight, days together, even at least till 1 week. No complications, no side effects, no ketamine induced hallucinations or anything, because maybe low dose. So they prefer, and there are so many studies are there that are non-AKI patients. It is not in AKI patients.
Now Srikanth has to close this, saying which is that.
David, one more thing I want to add.
Chapter. చెప్పు.
See, we don't give continuous sedation. We give a sedation wake. We'll see how the patient is opening up. When the patient is not opening up, we stop sedation till he wakes up. So we don't
Definitely.
pump
That is
the
the
sedation
protocol.
without having any assessment of the sedation. So when we know that patient is coming out of the sedation as early as possible, like when you stop the infusion, patient is easily wakeable and patient is coming out. So we can still continue sedation of what is of our choice.
So one addition, as David mentioned, I have a good experience of ketamine in using burns. So this works like a wonder drug in burns patients. Because whatever you give tons and tons of fentanyl or a midazolam combination, that doesn't work in burns. Ketamine works very well in a patient with the burns.
Any explainable reason, sir?
Explainable reason is, sir, it is a very good analgesic. Okay, and also it's a very good sedative. So sedation, analgesia, and basically is also an induction agent. So we don't give so much of induction doses. So patient will be, see, if you want to patient with the same amount of dose with the fentanyl and midazolam combination to have an analgesia and sedation, we need a more amount. Here the pain when you are doing a dressing in a patient with a burns, you suddenly wanted a strong dose of analgesic and sedative agent, followed by again you don't need much duration of action. But here, if you give a high dose of midazolam and fentanyl in this patient, for the same efficacy, you need to give a high dose and it will have a duration of effect will be high. And you will have a lot of other side effects like respiratory depression and other things. This we don't see in ketamines. That I
Sir,
found.
Sir, efficacy wise, fentanyl
Sir?
is 100 times more potent than morphine. And morphine is definitely potent than ketamine. Efficacy wise, pain relief. Then duration wise, ultra short is fentanyl. Ketamine is not ultra short. So both way, I don't think it is the right thing.
I will refer, sir. But it is
Once they are using, definitely there must be some evidence. Let them. Okay, we will find out the articles and see the difference between morphine, ketamine, and fentanyl, all tramadol in analgesia and treating burns patients.
Thank you. Thanks a lot.
Thank you. Sir, నాదో చిన్న డౌట్. యాక్చువల్లీ అంటే ఐ మీన్ లైక్ నాట్ కంప్లీట్లీ
శ్రీకాంత్ కుదరదు, నీ డౌట్ కాదు, నువ్వు క్లారిఫై చేయాలి అన్ని అంతే.
సార్ నా అది అంత టాలెంట్ ఉంటే మీరందరూ పెద్దవాళ్ళ ముందు సార్ అంత లేదు. యాక్చువల్లీ ఐసీయూలో ఇప్పుడు ఒకటి మెనింగోఎన్కెఫలైటిస్ అదే టీబీఎం పేషెంట్ ఉన్నారు సార్. లైక్ బిఫోర్ అడ్మిషన్ షీ హ్యాడ్ ఎ సీజర్ ఎపిసోడ్, బట్ తర్వాత షీ వాస్ క్వైట్ ప్రెటీ స్టేబుల్ అండ్ యాక్చువల్లీ థాట్ ఆఫ్ రూమ్ షిఫ్టింగ్. అది దేవుడు బాబు సార్ న్యూరోఫిజిషియన్ హ్యాస్ యాడెడ్ ట్యాబ్ ఆఫ్ లాక్స్ సార్ 400 mg. ఓన్లీ ఒక టాబ్లెట్ ఇచ్చాక మార్నింగ్ ఇచ్చాము, ఆఫ్టర్ 2.5 hours పేషెంట్ హ్యాడ్ సీజర్. అంటే ఓఫ్లాక్సిన్ ఇస్ నోన్ టు కాజ్, బట్ అంత ఫాస్ట్ గా ఓన్లీ టాబ్లెట్ కి దట్ మే బి కన్సిడర్డ్. అంటే పేషెంట్ హ్యాడ్ అదర్వైజ్ లైక్ లాస్ట్ సీజర్ ఎపిసోడ్ వాజ్ అరౌండ్ 8 days బ్యాక్. డిసీజ్ ఆన్సెట్ అయినప్పుడు ఆల్మోస్ట్ స్టేబుల్ స్టేజ్ లో ఉన్నప్పుడు దట్ సింగిల్ టాబ్లెట్ కెన్ ఇట్ కాజ్ or we should stop it? Preston withhold chesam sir, but he is insisting on continuing neurophysician. That can be considered.
Why tap off locks? Why? What is the reason for starting?
ఆయన కొంచెం LFT ఎలివేషన్ ఉంది, లివర్ సేఫ్ అని చెప్పి ఆయన అన్నారు సార్.
What is the blood? Any culture reports you have?
నో సార్. అసలు అంటే ఫెబ్రైల్ స్పైక్ గానీ ఇనిషియల్ గా వచ్చింది కానీ నౌ ద పేషెంట్ ఇస్ యాక్చువల్లీ ప్రెటీ కంఫర్టబుల్. నిన్న సీజర్ ఎపిసోడ్ వచ్చిన తర్వాత కొంచెం చూడండి మళ్ళీ అగైన్ నౌ.
Correct. What is the necessity of giving antibiotics when patient is stable and no?
అంటే ఆయన స్విచ్ చేస్తూ ఐవి నుంచి
So they have a tendency to switch to tablets of ofloxacin, tab septum or tab something else. That is not at all required, unnecessarily causing definitely it may cause. If it is side effect is there, it may cause. What is the necessity and urgency of giving, of weaning of there is no role of weaning of antibiotics without any evidence.
David, basically, ఈ పేషెంట్ కి ఇచ్చారు. I think probably this patient is already having a meningoencephalitis and high risk of seizures. So whether subclinical or clinical seizures. So with the addition of ofloxacin, I think it has exaggerated to clinical seizures అనుకుంటున్నాను నేను.
అందుకే అలాంటప్పుడు ఎందుకు ఇవ్వటం?
ఇక వాళ్ళు డిసైడ్ చేసుకోవాలి.
అంటే వన్ somebody is insisting to continue, then you can involve the ID specialist or evidence to continue this thing. You cannot argue a consultant that where is the evidence, but still we can convince him or you can request him to or change to other antibiotics, same efficacy like first or second generation cephalosporins.
అన్నా
చెప్పాను.
డేవిడ్, నువ్వు చెప్పిన అది సెంటెన్స్ లైఫ్ లాంగ్ అందరూ గుర్తుపెట్టుకోవాల్సిన సెంటెన్స్ ఇది. We cannot argue with the consultant.
అంతే కదా.
We have to show the evidence through third party. అంతే. To sustainably to be an intensivist in any institute.
లేకపోతే వాడు మన మీద కంప్లైంట్ చేస్తాడు, దీన్ని తీసి పడండి.
అంతే, అది మట్టుకు టేక్ హోమ్ మెసేజ్ ఇది. నోబడీ కెన్ సే నో టు దిస్.
అంతే, వాటితో ఆర్గ్యూ చేయకూడదు ఎప్పుడు. చాలా ఏవేవో ఉంటాయి. నన్ను ఒక బచ్చగాడు వచ్చి నన్ను అబ్జెక్ట్ చేస్తాడా అని ఉంటది. ఎందుకు మనకి ఇవన్నీ? మనం వీ హ్యావ్ ఫేస్డ్ ఆల్ దీస్ థింగ్స్.
దాటొచ్చాం, కరెక్ట్.
ఇప్పుడు ఏంటంటే ద న్యూ ఇంటెన్సివిస్ట్ కమింగ్ ఫ్రమ్ different places and they are working in ICU. They are initially itself starting arguing with the consultants. Where is the evidence? How do you give this thing? So that is not correct. They have a lot of experience and they are the bosses of
that patient.
Consultants, primary consultants. Even though is not correct, we should not argue. We have to give respect, and there are so many other ways to convince him, or the way of is talking to him, or in a different ways. But if you hit his ego, then your downfall will start.
Here I want one request to Mohan sir. Mohan sir ki oka request. Sir Mohan sir unnara?
ఏమో సడన్ గా వస్తారు, సడన్ మాయమైపోతారు. ఉన్నారు లేదు
సార్? సార్ ఏమో కౌన్సిలింగ్ చేస్తున్నారు సార్. నేను సురేంద్ర సార్. చెప్పండి సార్, సార్ చెప్తాను సార్. నేను బయట చెప్పండి సార్.
Mohan sir, request from my side to ISCCM board, because you are an executive member కాబట్టి ISCCM board ki ఏంటంటే, how to we have gone long way discussing and everything. We never discussed about how we have to project in the hospital ourselves, how we have to sustain ourselves in the community, how we have to improve our business, how we have to improve our own things. మనం పెద్ద పెద్దవి చేస్తున్నాం, ప్రైమ్ మినిస్టర్ పిలుస్తాం, ప్రెసిడెంట్ పిలుస్తాం, చేస్తున్నాం, కానీ అట్ ద లోకల్ లెవెల్ నౌ హౌ వీ హ్యావ్ టు సస్టైన్ అనేది మాత్రం మనం చేయట్లేదు సార్. ఐ థింక్ ప్లీజ్ పుట్ ఫార్వర్డ్ టు ఐసిసిఎం నేషనల్ బోర్డ్స్.
అలా కాదు. ఆల్రెడీ రామకృష్ణను వర్క్ షాప్ చేశాడు దాని గురించి, హౌ టు నెగోషియేట్, హౌ టు సస్టైన్, హౌ టు ప్రొజెక్ట్ అనేది. డేవిడ్ తెలుసు కదా? డేవిడ్
ఏంటది?
రామ్కి చెన్నై రామ్కి చేశాడు కదా ప్రోగ్రామ్, హౌ టు నెగోషియేట్, హౌ టు బి షోకేస్ అవర్ డిపార్ట్మెంట్ అనేది.
అవునవును.
సో అదే, అందుకంటే ఏం లేదు. సో అంతే చేసేది.
అది ఒక నేషనల్ లెవెల్లో రావాలి సార్.
అలాగే రేపు కలుస్తున్నాను. మీటింగ్ అగర్తల రేపు 8th 9th కలుస్తున్నాను. ఆ 4 పాయింట్లు ఏంటో చెప్పు. ఆ 4 పాయింట్లు పెట్టి మాట్లాడతాను.
హలో,
హౌ టు సస్టైన్, హౌ టు ప్రొజెక్ట్, హౌ టు.
అది మీరే చేయండి, బికాస్ దిస్ ఈస్ ఫ్రమ్ అన్ ఎక్స్పీరియన్స్ ఆఫ్ అన్ ఐడి కమిటీ. సిట్స్ అని కాన్ఫరెన్స్ ఉంది కదా, 2010 లో దే హ్యావ్ ఫార్మ్డ్ ఏ కమిటీ, సిట్స్, ఇన్ఫెక్షస్ డిజీజ్ స్పెషలిస్ట్. సో డ్యూరింగ్ their 2-day conference, half day was by the infectious disease specialist, how we have to get a referrals, how we have to project ourselves in the community, in the hospital, and how to get a business.
సరే, తర్వాత ఇప్పుడు కెన్ యూ క్లోజ్ ద రిఫ్లెక్ట్ ద ఎర్లియస్ట్ ఫాస్ట్ బైస్?
Yesterday I downloaded, sir.
నాకు
I'll
ఈరోజు
just-
డేవిడ్, మీరు, సతీష్, వరలక్ష్మి అందరూ కూర్చొని
ఇది రేపు వెంటిలేటర్ వర్క్ షాప్ అయిన తర్వాత ఎల్లుండి అవతల ఎల్లుండి నుంచి వీళ్ళు ఆన్
చేయండి.
సండే విల్ ఫిక్స్ ఇట్.
Yes,
సరే,
Sunday will fix it and we'll.
మీరు చేసేయండి, నేను ఉండను.
మీ టాపిక్స్ పంపించండి డేవిడ్ గారు. మీరు చెప్పారు కదా టాపిక్.
థ్యాంక్ యూ.
అలాగే పంపిస్తాను.
బాయ్.
థ్యాంక్ యూ.
థ్యాంక్ యూ
Srikanth. Thank you, Srikanth. Nice presentation, and thank you all for your.
Thanks, Srikanth.
Thank you.
Thank you, sir. Thank you, sir.
Thank you,
Sir,
Srikanth.
Thank you, madam.
thank you, sir.
Thank you, sir.